Hi, in this video, I'll be talking about how we treat stage 3 breast cancer. I'll describe what stage 3 breast cancer means, and then the different types of treatment you might hear about after you've been diagnosed when you see your medical team. Stage 3 breast cancer includes both the size of the tumor and the number of lymph nodes. If the tumor is over 5 centimeters, that alone will make this a stage 3 cancer. Or if 4 or more lymph nodes are positive, that's also stage 3 breast cancer. You don't have to have both to have stage 3 breast cancer. So you can have a tumor that's less than a centimeter, but have 12 positive lymph nodes. That makes it stage 3. Or you can have negative lymph nodes and a 6 centimeter tumor. That tumor is also stage 3. When we talk about treating stage 3 breast cancer, we talk about local regional treatment, which is treatment of the breast and neighboring lymph nodes. Then we also talk about systemic treatment, or treatment that goes through the whole system to decrease the risk of the cancer coming back in other parts of the body. I'm going to start with local regional treatment, then I'll go to systemic treatment, but I'll also talk about times we would give systemic treatment before surgery. So there are two main types of surgery for breast cancer, actually regardless of what stage you have. There's breast conserving surgery and there's mastectomy. I'll talk about breast conserving surgery first. Breast conserving surgery means we preserve the shape of the breast and most, if not all, of the breast. You might hear this called lumpectomy or partial mastectomy. There are a host of other terms, but they're all referring to the attempt to keep the breast, not remove the whole breast. Then there's mastectomy, which is removal of the whole breast, and we create an incision across the chest wall, removing as much of the breast tissue as possible. If you have a mastectomy, you can have reconstruction. Reconstruction of the breast means that you end up having your breast reconstructed and you have a breast mound so that when you wear clothes, you don't need a prosthesis and it appears as if you have both breasts. There are two types of reconstruction. One is implant reconstruction, where we use first a skin expander and we expand the skin by injecting some saline into the skin expander. We have other videos on reconstruction. Or you can use your own tissue from your abdomen, your back, or even your buttock to create a new breast mound. The thing with reconstruction and stage 3 breast cancer is that most people with stage 3 breast cancer will be advised to have radiation therapy, or at least it will be part of the discussion. And in general, we recommend that you wait to have reconstruction until after radiation therapy for a couple of reasons. The first is that planning of radiation is more straightforward and it's easier for us to avoid the heart, the lung, normal tissues when there is no breast mound present. The other reason is that radiation therapy can change the appearance of not only our normal breast, but also a reconstructed breast. So if you have implant reconstruction, radiation can constrict or contract the capsule into which the implant was placed. This can lead to a less appealing cosmetic appearance. You may not be as happy with the appearance, and it can also lead to tightness because that capsule has contracted. If you use your own tissue, that tissue also will get smaller. Now, this may not bother everybody. They may not mind if the reconstructed breast gets smaller. But for a lot of people, they go into reconstruction hoping to be symmetric on both sides, or they pick a breast size they would like based on their preference. So you can see why waiting on radiation therapy after reconstruction might be the right thing to do. I do recommend that you meet with a plastic surgeon, though, before you make your treatment decisions. It's good to have that relationship and you kind of know what to expect. We recommend that you wait about 6 months after radiation therapy to have your reconstruction. And it's just kind of nice to know who will be doing it and when. And then when it's time, you don't have to go and meet a new physician. I haven't yet talked about the lymph nodes. In stage 3 breast cancer, we will always assess the lymph nodes. If the sentinel node is positive, or if we know going in that the nodes are positive because they feel enlarged or matted, we will remove level 1 and level 2 lymph nodes. I can't tell you how many lymph nodes you have. Everybody has a different number of lymph nodes. We actually do the surgery based on the anatomy of the armpit. So the lymph nodes are in the armpit, and we use the muscles to help us define the anatomic area. Then the fat pad is removed, and the pathologist identifies the nodes. So that takes a lot of painstaking work. And you can have anywhere from 4 to, I've seen 60 lymph nodes in one of my patients. So we don't know when we go in how many nodes are positive. We don't know how many nodes you have at all. So for stage 3 cancer, 4 or more nodes positive or a tumor 5 centimeter or more will give you stage 3 disease. You may go to surgery thinking it's stage 1 because the tumor is small, and if the lymph nodes end up being positive, being told that this is stage 3 breast cancer. That's not uncommon. It doesn't mean you've done anything wrong or that the doctor's done anything wrong. All right, I've talked about removal of the tumor with a mastectomy or breast conserving surgery, reconstruction, a little bit about radiation therapy, and talked about the lymph nodes. Now I'm going to talk about systemic therapy. Systemic therapy goes through your whole system, and as I mentioned before, the purpose is to decrease the likelihood that cancer will come back in other parts of your body, liver, lung, bone, for example. Those are areas that can come back. So we want to treat your whole system. Even if your scans are negative, we can't tell you for sure that the cancer hasn't moved to other places, and we want to treat it early before those cells get established and are visible on a scan. So we're treating what we call micrometastatic disease. We just can't see it. You have to have about 1 billion cells together to see something on an X-ray or a bone scan or a CT scan of the liver, and we want to treat the cells before they become that numerous. So there are 3 types of systemic therapy. The first is chemotherapy, and I'm going to cover it first because in stage 3 breast cancer, nearly 100% of people will be offered chemotherapy, and we give chemotherapy first. So chemotherapy is given by vein. There are some oral chemotherapies, but the best therapy, chemotherapy for stage 3 breast cancer, is given by vein. This can be given through an IV in your arm, or for some people, a semi-permanent IV that we put in under the skin. We can also put in a semi-permanent IV in your arm that's called a PICC line, P-I-C-C. So we give the chemotherapy through an IV. You'll get that in the treatment center. Your nurse or pharmacist will give you, in some places the doctor gives chemotherapy, and you will get medicine by mouth or IV to help decrease any side effects that you might get. Then we give you the chemotherapy, and that's given over a couple hours. If you're getting targeted therapy, it's a little longer. And then the IV comes out and you go home with medication in the event you get any side effects. The type of chemotherapy you get will depend on a few things, but it generally will last about 6 months. Chemo is not given daily. It's given as often as weekly or as infrequently as every 4 weeks for, again, 6 months. Next, I'm going to talk about targeted therapy. Targeted therapy is given only to people whose tumors are HER2 positive. HER2 stands for Human Epidermal Growth Factor Receptor 2, which is why we abbreviate it. Targeted therapy works directly on the cells that have HER2 proteins in abundance or many copies of the HER2 oncogene. Targeted therapy goes right to those cells and targets that protein. That's why we call it targeted therapy. There are 2 types of targeted therapy in HER2-positive breast cancer. The first is called trastuzumab, and the second is pertuzumab. Trastuzumab we've had for many, many years. We try to give the medication for a full year. At first, it might be given weekly. Then we time it with your chemotherapy so you don't have extra visits. And when you're all done with chemotherapy and the trastuzumab continues, you can get it every 3 weeks. It depends on if you're on other therapy like bone strengtheners. The frequency can be changed a little bit. And we change the dose depending on how often you get it. Now, we do try to give pertuzumab and trastuzumab, that's called dual HER2 blockade, to people with stage 3 breast cancer. In a moment, I'll talk about getting treatment before surgery, but if one has a great response to trastuzumab and pertuzumab before surgery, that pertuzumab, we do try to continue it for a full year, but many people get diarrhea and they're not able to stay on it. You haven't done anything wrong. Your doctor hasn't done anything wrong. It's just a somewhat difficult medicine to tolerate. So to summarize, we give dual HER2 targeted therapy for people with stage 3 breast cancer, the trastuzumab for a year, the pertuzumab for 12 weeks, up to a year if you tolerate it. If your tumor is HER2 negative, you won't be getting targeted therapy. Next, I'm going to talk about endocrine therapy. Endocrine therapy is also called hormonal therapy. This is not the same as hormone therapy or hormone replacement therapy. We're not giving you estrogen. We use hormonal therapy in people whose tumors have the estrogen receptor, progesterone receptor, or both. We'll have a link to our video about hormone receptors. If your tumor is ER or PR positive, we call that hormone receptor positive breast cancer, and we know that by interfering with the way estrogen in your body gets to any remaining tumor cells can improve your likelihood of cure. So if the tumor has has estrogen and progesterone receptors, we want to block or get in the way of the dance between those cancer cells and estrogen in your body. Even after your ovaries stop working, you still make estrogen. Even if you're a man, you still make estrogen. And we know that we can block the production of estrogen in your body and improve your chances of cure. First, I'm going to start by talking about tamoxifen. Tamoxifen is a funny drug. It actually is a weak estrogen, and it mimics estrogen and gets in the way of estrogen getting to the estrogen receptor. I'm going to use my hands to show you. If my hand is the tumor cell and this is the estrogen receptor, tamoxifen, well, let's start with estrogen. Estrogen comes in and stimulates the cells to divide. If tamoxifen comes in, now estrogen can't get in there. So it doesn't lower estrogen in your body, right? The estrogen's still circulating because it's not being nabbed up by the estrogen receptor on the tumor. It's just that the estrogen can't get to the cell to stimulate the cell to divide. Tamoxifen has some beneficial estrogen-like effects, like it can improve bone density and lower cholesterol. And it also has some anti-estrogen effects, like hot flashes and vaginal dryness. The day-to-day, really life-affecting side effects are because tamoxifen is blocking a stronger estrogen from getting to estrogen receptors all over your body, not just on cancer cells. So aromatase inhibitors are the other class of endocrine therapy, and they work in a different way. They actually lower estrogen in your body. So tamoxifen doesn't change the estrogen level in your body. Aromatase inhibitors block the conversion of testosterones, androgens, to estrogens. And they do that by blocking the enzyme aromatase. So the enzyme that converts male sex hormones to what we think of as female sex hormones gets blocked. And so your body has less estrogen in it. Even after the ovaries stop working, we make lots of estrogen and other tissues in our body, like breast tissue, fat, the adrenal glands all make estrogen. So even if you've gone through menopause or you don't have ovaries, you still make estrogen. And by blocking the production of estrogen, we lower estrogen in the body and sort of starve the tumor cells. I have covered a lot. I've talked about surgery on lymph nodes in the breast. I've talked about radiation therapy. I've talked about targeted therapy and chemotherapy. I've talked about endocrine therapy. I do want to talk about giving systemic therapy before surgery. There's an advantage to giving systemic therapy before surgery. The first thing is that it can improve the surgical outcome. So in somebody who wants to have breast-conserving surgery, but the tumor's too big, there are other reasons to get systemic therapy before surgery. If, for example, you want to find out if you have an inherited mutation, and if you did, that would change the kind of surgery you would have, you need some time to see a genetic counselor and get genetic testing done and get the results and make a decision. Getting systemic therapy first, not only does it improve the surgical outcomes, but it can buy you some time with no negative impact on your outcome. So remember, people who want to have surgery first say, I want to keep the cancer from spreading. I don't want it to be too late. Well, by treating you systemically, we decrease the likelihood that those cells will grow and spread. So there's actually a theoretical reason to think that systemic therapy before surgery would help, but that's not actually the case. So in most people, most studies, the outcome is the same whether you get chemo first or surgery first. The surgical outcome can be better if you have systemic therapy first. But if you had surgery first and you're wondering, should I have had systemic therapy first? Most likely it's just fine. It's just some people prefer to shrink the tumor as much as possible. The other thing it can do is it can make the lymph nodes easier to remove if they're all kind of stuck together. Shrinking them first with systemic therapy can help. We generally give chemotherapy and targeted therapy if it's indicated, if the tumor is HER2 positive, before surgery. In general, we don't give endocrine therapy before surgery. So the order, if you're going to get chemotherapy first, systemic therapy first, would be systemic therapy with chemotherapy and targeted therapy if appropriate, then surgery. Some people get additional systemic therapy after that. Then you would get radiation therapy and then endocrine therapy. The targeted therapy continues for a full year, and the time you put in before surgery counts for that whole year. I've covered a lot. I hope this has been helpful. Click like and subscribe. You can drop us a comment or question below. To follow us on Instagram, we have a lot of great stuff on our new Instagram channel. And as always, you can go to yerbba.com to get your personalized report.